Hello guys, welcome back to the Physics Wala Method YouTube channel, and I'm Dr. Patil, and here we are continuing the Read Harrison's with Dr. Santosh series. In the previous video module, we have discussed about the heart failure. I hope you have got the concepts clear. What is heart failure? How do we classify? How we make a diagnosis? And how we manage. So today we're going to spend another 15 minutes updating ourselves with the most latest knowledge about heart failure. So first of all, when we discussed heart failure, we learned that heart failure leads to certain adaptive changes. So there is activation of RAS, there is activation of sympathetic nervous system, and in the previous video we discussed about it, right? So when RAS gets activated and when sympathetic nervous system get activated, it leads to worsening of the heart failure. So it is burdensome, harmful adaptation. Similarly, heart failure leads to some beneficial adaptations. What are the beneficial adaptations? There was the activation of the natriuretic peptides which benefit the patient with heart failure. So in terms of management, हम इसी के साथ खेल रहे थे, right? We were blocking the RAS, we were blocking the sympathetic nervous system, and we were trying to support the activity of natriuretic peptides by blocking the neprilysin. That has been the standard treatment. We received some add-on benefit by adding the SGLT2 inhibitors. The logic behind that I have discussed in the previous video module. Now, does that mean that if I start this standard treatment, all patients of heart failure, their life will get better, their mortality will come down? Yes, mortality will come down, but still it is not going to be normalized, right? The mortality risk is reduced, not completely normalized. Patients with heart failure, despite standard treatment, many of them continue to be symptomatic and many of them inch towards death. So what we are trying to learn today is what research has helped us to understand in the recent years about heart failure mortality and its management beyond the standard treatment. इतना तो clear है that despite standard treatment, patients can continue to be symptomatic. So there is need for some newer drugs to be able to help them get better with symptoms. And despite standard treatment of RAS blockade, sympathetic nervous system blockade, and neprilysin blockade, patients with heart failure still have higher mortality than other category of patients. So there was need for drugs to further lower the mortality risk. So let us look at what all has happened in last few years with respect to heart failure diagnosis and management. So first up, we will look at what new drugs have come up and what is their role in the management of heart failure. And then for the diagnosis or prognostication of heart failure, we have been standardly using the BNP or N-terminal proBNP as the prognostic marker as well as the diagnostic biomarker. But obviously there was need for some more biomarkers which can help us diagnose or prognosticate. So have we developed any newer biomarkers? And then there is something called as cardiac resynchronization therapy and implantable cardioverter defibrillator. What is their role in the management of heart failure? That is what we will discuss today. We will begin with the newer drugs. I have already made it very clear that despite use of standard treatment reduces the mortality risk, but still mortality risk is on the higher side in patients with heart failure, right? So what can we do to reduce that mortality? So there was attempt, the point I want to tell you is that the mortality most often is quite sudden. Means patients may not have any forewarning signs or long standing worsening of symptoms before they die. Lot of patients with heart failure, they die suddenly. So in patients with heart failure, there is increased risk of sudden cardiac death. And what we have learned over the years is this risk of sudden cardiac death correlates with patient's ejection fraction. जितना ejection fraction low है, sudden cardiac risk का death उतना ही ज़्यादा है. So this correlates with low ejection fraction. Lower the ejection fraction, higher is the risk of sudden cardiac death. Now what could be the reason why patients suddenly die? Most of them, right, they die because of increased risk of, they die because of development of ventricular tachycardia or ventricular fibrillation, VT or VFib. So if I have to achieve the mortality reduction in these patients, I have to minimize the risk of developing VT, VF. We have to remember this point. Okay. Now coming to the drugs. What newer drugs we have developed? One drug which you may be familiar, there is a drug called as Ivabradine, which is a blocker of funny currents, right? So it blocks the funny currents. Now how this drug will help in a patient with heart failure? See, again, let me summarize what is the standard treatment for a patient with heart failure. ST stands for standard treatment for heart failure. हम क्या क्या यूज कर रहे हैं standardly for a patient with heart failure? We are using AC inhibitors or ARBs or ARNI, right? A combination of neprilysin inhibitor and ARB. Then we are using beta blockers. Then we are using mineralocorticoid receptor antagonist like spironolactone, plus we are using SGLT2 inhibitor. This had been our standard treatment. So why beta blockers are helpful? Beta blockers reduce the heart rate. Increased heart rate is harmful for a patient with heart failure. Good evening everyone. Good evening everyone. SGLT2 inhibitor, right? These are the drugs which are used as a standard treatment for heart failure. यहाँ पे beta blockers का main role क्या है? Sympathetic nervous system activated है in patients with heart failure, and that is increasing the heart rate. Increasing heart rate causes reduced time for diastolic filling, and that causes worsening of the heart failure. Increased heart rate also increases the myocardial oxygen demand. नहीं मिलेगा तो heart और भी fail होगा. So we try to achieve lower heart rate with beta blockers. जितना lower होगा उतना beneficial होगा for a patient with heart failure. But if I am not able to achieve the significant lowering of the heart failure, in such cases we can use Ivabradine as an add-on. So normally हम क्या करेंगे, heart failure में standard treatment के साथ एक goal है, right? Heart rate goal in patients with heart failure. Heart rate goal क्या है? It should be less than 70 per minute. If I'm not able to achieve 70 per minute with beta blocker alone, I can add Ivabradine. Ivabradine reduces the heart rate, right? Funny sodium or funny current channels. By inhibiting that, it can decrease the heart rate. So when is it indicated? Indicated if heart rate is more than 70 per minute despite use of optimal dose of beta blockers. Despite use of optimal, जितना भी patient tolerate कर सकता है, right? Optimal dose of beta blockers. Now, is this drug approved by the US FDA? Yes, this drug has been approved by the US FDA. So this has the FDA approval for this indication, right? Heart failure में standard treatment start करो, उसके बावजूद अगर heart rate 70 के ऊपर ही रहता है, for further lowering of the heart rate, you can use Ivabradine. Okay. Then we have another drug which has been the talk of the town in the recent times called as omecamtiv mecarbil. What is it? It is a myosin activator. It is a myosin activator. So by acting myosin, it increases the force of contraction of the ventricular muscles during the systole. So this can help you give symptomatic benefits. But studies have shown that symptomatic benefit is minimal, mortality में कोई benefit नहीं है, and because of that US FDA has disagreed to give it approval. So this is not US FDA approved. This is again an MCQ point that I want you to remember, right? So FDA has not approved. It has rejected despite multiple requests from the company. It has rejected the approval. So it is a new drug. Mainly MCQ में क्या पूछेंगे? They will ask the mechanism of action, but it is not used in practice. Now we have one more drug called as Vericiguat. Can you remember any other drug which sounds similar, which we discussed when we were talking about the pulmonary hypertension? Pulmonary hypertension. Good. Which we are talking about when we have the pulmonary hypertension. Yes, that is Vericiguat. What is Vericiguat? It is a guanylyl cyclase stimulator. So that causes vasodilatation. Same Vericiguat, but instead of pulmonary hypertension, we are using it for patients with heart failure. It is a guanylyl cyclase stimulator. Guanylyl cyclase stimulator. FDA has approved it for the treatment of heart failure. So now we have learned about three new drugs: omecamtiv, Vericiguat, and Ivabradine. Ivabradine is when your beta blockers are not able to achieve a lowering of heart rate. Standard treatment हम दे रहे हैं, optimally tolerated beta blocker दे रहे हैं. Yes, it's a very good point. Generally, obviously, When I say heart failure का हम standard treatment बात कर रहे हैं, so we are mostly talking about heart failure with reduced ejection fraction. EF कम होगा, patient despite being symptomatic with all the standard medications, ejection fraction less than 35%, and जो dyspnea grade है वो NYHA 2 से 4A तक we can consider using the Ivabradine. Vericiguat is the newest drug which has received the FDA approval, and omecamtiv mecarbil is a drug which has not received the US FDA approval. So these three are important MCQ points for the NEET PG. Now after the drugs, we will also take a look at the newer biomarkers. Why this is important? Because we are in search of biomarkers for various conditions. For example, let me give you an example of renal injury, right? What is the standard marker for the kidney dysfunction? We use creatinine and blood urea. But they are not foolproof methods, right? You can have certain conditions where despite having normal kidney functions, you can have high creatinine. For example, if you go to gym and you use this supplement called as creatine monohydrate, that gets converted to creatinine after muscles have used it for generation of ATPs, then your creatinine levels will be high. So in such cases, you will have falsely elevated creatinine levels, and then you will think that your kidneys are dysfunctional. So we needed additional biomarkers which tell us about the kidney function, right? So can anybody tell me what are the biomarkers that we can use in place of creatinine for the diagnosis of renal dysfunction? Okay, well, so there is a marker called as NGAL, NGAL. Then there are similar markers for the renal dysfunction. It's like cystatin C, which is another marker for the renal injury, which is not influenced by your muscle mass or creatine supplementation. So they can be used. So similarly, we were in search for newer biomarkers for patients with heart failure. And these are the three newer biomarkers. Among them, if you ask me, sir, which one I should remember, it is the soluble ST2. Studies have shown that its levels correlates with the prognosis of heart failure. BNP levels also correlate with the prognosis of heart failure. BNP level जितना high रहेगा उतना prognosis bad रहेगा. वैसे ही ST2 levels जितने high रहेंगे उतना ही prognosis poor रहेगा. So apart from that, we have galectin 3 and growth differentiating factor 15. So these are the three newer biomarkers for heart failure. They mainly are used for prognostication rather than diagnosis. Diagnosis के लिए अभी भी standard BNP और NT-proBNP है. Okay. Now that is about the biomarkers. Why is this important? It is important from the MCQ perspective. They will ask you which of the following is a or is not a newer biomarker for patients with heart failure. So they will add biomarkers for renal dysfunction, biomarkers for the liver dysfunction, right? And then they will ask you to pick or refute from the heart for the heart failure. So you should know which are the newer markers for heart failure, which are the newer markers for myocardial injury or MI, which are the newer markers for the renal dysfunction. Okay. Amarish Kumar, tadalafil is a phosphodiesterase 5 inhibitor which is used for the treatment of pulmonary hypertension and various other indications. Obviously, tadalafil will cause vasodilatation. Vericiguat is another drug which causes vasodilatation, and we use it for the treatment of pulmonary hypertension, which is acting through guanylyl cyclase stimulation. वैसे ही guanylyl cyclase stimulation can be used for heart failure because vasodilatation is beneficial for heart failure because that reduces the burden on the heart, because vasoconstriction is a burden on the heart, right? So that is why we were using this drug called as Vericiguat. Okay, so that is about the newer biomarkers. Now the next thing I need to learn is the concept of CRT and ICD. I have already made a statement saying that heart failure is associated with increased risk of sudden cardiac death. And उसका main reason क्या है? Developing fatal ventricular arrhythmias like ventricular tachycardia or ventricular fibrillation. Okay. Second thing that we have noticed is GDF stands for growth differentiating factor and ST stands for suppressors of tumorigenesis, ST. Okay. So दूसरा क्या है? Heart failure, especially in some individuals, progresses much rapidly than other individuals. And वो rapid progression के लिए भी हमने कुछ reasons find out किया है. उनमें से एक reason है development or having bundle branch blocks. So when you have, let me say, right bundle branch block or left bundle branch block, there is an asynchrony created between the ventricular contraction. For example, let me say that you know that SA node is the pacemaker of the heart, right? and then you have a AV node. SA node delivers the wave of electricity or depolarization to AV node. AV node will deliver it to his bundle. His bundle will divide into right bundle branch and left bundle branch block, left bundles branches, and eventually it is the Purkinje fibers which will take the electricity to the ventricular myocardium to cause the depolarization. Now, if I cause one of the bundle branch block, right? Do you think both right ventricle and left ventricle will get simultaneously depolarized? No. पहले कौन सा depolarize होगा? Right का, जहाँ पे block नहीं है, right? The left, अगर मैंने left को block किया है, so then left will take longer time to get depolarized. So now I have created a asynchrony between the ventricular depolarization. Normally almost simultaneously depolarize होता है, but here I have created an asynchrony by blocking one of the bundle branches. This also contributes to worsening of the heart failure. Despite standard treatment, right? If I'm noticing worsening of the patient's heart failure, one of the reason could be having the bundle branch blocks. So if I get the asynchrony back to normal synchronization, दोनों अगर if I do something to make sure that right ventricle and left ventricle get depolarized almost simultaneously, then I can slow down the progression of heart failure. So that is something that I need to think about achieving. And the second thing that I need to think about achieving is, because VT or VF are one of the leading causes for sudden cardiac death in heart failure patients, I might have to think of preventing it. अब prevent कैसे कर सकते हैं? Either we can think of giving antiarrhythmic drugs. Studies have shown that use of antiarrhythmic drugs did not give us much benefit, and in fact drugs के side effects were more counterproductive. Now, if I have an arrhythmia, what is the best treatment? Obviously, giving the shock is the best treatment for a patient with arrhythmia. So, if a patient is likely to develop suddenly a VT or VF, if I can shock it immediately, I can revert it to sinus rhythm. So, obviously, I cannot run behind the patient with a defibrillator continuously. So, I want to implant a shocking device inside the patient. So, when we implant the shocking device inside the patient, we call it as ICD, implantable cardioverter defibrillator. And if I play with the conduction system of the heart to bring the synchrony back between the two chambers depolarization, then we call it as cardiac resynchronization therapy. These two are our additional attempts to help the patient get better with symptoms, slow down the progression of heart failure, and reduce the risk of death. Now the question is, when do I use them, right? I've already made a statement saying that the risk of sudden cardiac death correlates with the patient's ejection fraction. जितना लो है उतना VT VF होने का रिस्क ज़्यादा है, उतना sudden cardiac death का रिस्क ज़्यादा है. So that is why when we have a patient with heart failure, right, our first step is the standard treatment. Standard treatment के बाद, if patient has what we call as refractory heart failure, that is where heart failure is not responding, right, then we will think of the additional options. अब refractory heart failure क्या है? When despite standard treatment, patient symptoms are not controlled. So we can think of drugs like Ivabradine and Vericiguat. Now apart from that, we have to consider for the cardiac resynchronization therapy, and we have to think of the implantable cardioverter defibrillator. How we will make a decision about this? It is primarily going to be based on patient's two things: status of symptoms and the ejection fraction. So what we have noticed from our experience of studied is that lower the ejection fraction, higher is the risk of sudden cardiac death, and higher is the symptom status. जितना ज़्यादा shortness of breath है, उतना ज़्यादा sudden cardiac death का risk भी ज़्यादा है. So that is why we have to look into patient's symptom status and ejection fraction. How do we assess the symptom status? We assess the symptom status with the help of New York Heart Association grading of dyspnea, right? So what we will do, if I have a patient with heart failure and his ejection fraction is less than 35%, this definitely calls for the additional intervention, right? When it is less than 35% with New York Heart Association grade of dyspnea, New York Heart Association grade of dyspnea, grade 2 से लेके grade 4A, सी आपको ग्रेड 4 शायद पता है, ग्रेड 4 dyspnea is when patient is having shortness of breath at rest. And then what is this A, grade 4A? See, please remember, grade 4 is shortness of dyspnea at rest. ए क्या है, पेशेंट इज एम्बुलेटरी, मतलब ही इज शॉर्ट ऑफ ब्रेथ बट स्टिल शॉर्टनेस ऑफ ब्रेथ के साथ चल फिर रहा है, दैट इज ए. ए पेशेंट इज नॉट एम्बुलेटरी, आई विल जस्ट मेंशन इट एज ग्रेड 4. ग्रेड 4 इज द मोस्ट एडवांस्ड फॉर्म, राइट. वहाँ पे these procedures may carry the risk, so हम we are not taking any step. But grade 2 से grade 4 है, ejection fraction less than 35% है. Such patients ejection fraction low है, symptoms high हैं, so they are at risk of developing the sudden cardiac death due to VT or wave. They would require implantable cardioverter defibrillator. Okay. Now, if I have a patient whose ejection fraction is less than 30%, in that case symptoms अगर mild हैं तब भी they can get benefit from implantable cardioverter defibrillator. So अगर grade 1 है but ejection fraction और भी low है, then also we can consider implantable cardioverter defibrillator. तो हमें क्या करना होगा, हार्ट फेलियर डायग्नोस करेंगे, ejection fraction देखेंगे, अगर वो 35% से कम है we will take a look at the patient's डिस्निया ग्रेड. अगर वो ग्रेड 2 से ग्रेड 4A के बीच में है तो इन एडिशन टू स्टैंडर्ड ट्रीटमेंट वी विल आल्सो पुट देम ऑन इम्प्लांटेबल कार्डियोवर्टर डिफिब्रिलेटर. आफ्टर योर स्टैंडर्ड ट्रीटमेंट अगर हम पेशेंट के सिम्टम स्टेटस को इंप्रूव नहीं कर पा रहे हैं, ही रिमेन्स इन NYHA ग्रेड 2 to grade 4A, then we will consider, obviously, like despite standard treatment, then we will consider putting the patient on ICD. Okay, that is one thing. We decided about ICD. Now, when do I consider the cardiac resynchronization therapy or CRT? When do I consider cardiac resynchronization therapy or CRT? Resynchronization कब चाहिए, जहाँ पे दोनों वेंट्रिकल की डीपोलराइजेशन ऑलमोस्ट साइमल्टेनियसली नहीं हो रहा है, राइट. एक का पहले हो रहा है, दूसरे का बाद में. सो इन सच केसेस what should I do? I have to consider resynchronization therapy. Obviously, स्टैंडर्ड ट्रीटमेंट को जो रेस्पॉन्ड कर रहा है उनको तो ज़रूरी नहीं है, बट इफ पेशेंट्स ejection fraction is less than 35%, along with that patient has got New York Heart Association grade 2 से grade 4A dyspnea है. बट अलॉन्ग विद दैट मुझे कैसे पता चलेगा कि बंडल ब्रांच ब्लॉक है? वेन एवर देर इज अ बंडल ब्रांच ब्लॉक द QRS ड्यूरेशन बिकम्स वाइडर. तो नॉर्मल QRS ड्यूरेशन क्या होता है? नॉर्मल QRS ड्यूरेशन इज लेस देन 120 मिली सेकेंड्स, यूजुअली 80 to 100 मिली सेकेंड्स. 120 मिली सेकेंड से ज़्यादा है तो यू कैन से QRS ड्यूरेशन इज वाइड. ओके, सो व्हेन वी हैव EF लेस देन 35, NYHA ग्रेड 2 से ग्रेड 4 है एंड देर इज वाइड QRS. नॉर्मल कितना होना चाहिए QRS? लेस देन 120 मिली सेकेंड्स. जब ये 150 मिली सेकेंड से ज़्यादा है, देर इज डेफिनेट वाइडनिंग ऑफ द QRS, देर इज डेफिनेट एसिंक्रोनी बिटवीन राइट एंड लेफ्ट एट्रियल depolarization. So wide QRS with the QRS duration more than or equal to 150 milliseconds with left bundle branch block. Obviously यहाँ पे भी हम पहले क्या करेंगे, स्टैंडर्ड ट्रीटमेंट, राइट. सो अगर डिस्पाइट स्टैंडर्ड ट्रीटमेंट पेशेंट रिमेन्स इन NYHA grade 2 grade 4A symptom status with ejection fraction less than 35%, in such cases we will consider कार्डियक रीसिंक्रोनाइजेशन थेरेपी. बेसिकली यहाँ पे क्या होता है, एक पेस मेकर का लीड हम हार्ट में डाल देंगे, जो राइट एट्रियम का राइट वेंट्रिकल के जैसे ही डीपोलराइजेशन स्टार्ट होगा उसी टाइम दिस विल कॉज द डीपोलराइजेशन ऑफ द लेफ्ट वेंट्रिकल इंस्टेड ऑफ वेटिंग फॉर द नेचुरल डीपोलराइजेशन ऑफ द लेफ्ट वेंट्रिकल. सो दैट हेल्प्स अस टू अचीव द resynchronization. Now the question is, they will give you the scenario in the MCQ and then ask you to decide कि आप यहाँ पे ICD consider करोगे या CRT या दोनों, right? So when we use both ICD plus CRT, it is usually abbreviated as CRT-D. D stands for defibrillator. So what I'll do is I'll give you a scenario. You should tell me whether you will consider ICD in this patient or. So I have a patient A who is a case of heart failure with reduced ejection fraction. Okay, so for that he has been started on ARNI. He's receiving the treatment with ARNI plus he is getting optimal dose of beta blockers, plus he has been started on Ivabradine because heart rate was, we are not able to achieve a good control of heart rate. So he has been started on Ivabradine, plus we have also added spironolactone, plus as usual with the recent recommendation we have added SGLT2 inhibitor. Now despite all of this, right, so despite this treatment, patient is in, let me say, New York Heart Association grade 3 dyspnea. Okay, and when we look at this patient's ECG, right, ECG shows wide QRS. The QRS duration is, let me say, 160 milliseconds, and I see a prominent S wave in lead V1 and a prominent R in lead V5 or V6. So these are pointers to suggest that mainly we are dealing with left bundle branch block. Okay, so those who are not familiar with ECG right now, you don't have to worry too much. Going forward, we will definitely learn all of this. So now tell me, what all options we can consider here? Should I do, one option is CRT alone. Second option is CRT with the ICD, which is called as CRTD. D stands for defibrillation. Third option is only ICD alone. Fourth option is none. So what can I offer for these patients? This patient, heart failure with reduced ejection fraction hai. I didn't mention about the ejection fraction, right? So let me also write about echo findings. So echo में हमें ejection fraction मिल रहा है, EF is 24%. So now tell me, what would you like to consider in this patient? So let me take you back to the scenario, right? Heart failure है, हम standard treatment देंगे. Standard treatment के बावजूद अगर patient continues to be in New York Heart Association 2 to grade 4 symptoms, ejection fraction low है, such cases they might require ICD and resynchronization therapy. Resynchronization therapy की ज़रूरत क्यों है? Because with progression of the disease, heart failure और worsen होता जाएगा if there is asynchrony between right and left ventricular contraction. That asynchrony can come because of the bundle branch blocks. दूसरा क्या है? Because of the heart failure, reduced ejection fraction and higher symptom status, there is increased risk of developing sudden cardiac death due to VT and VF. तो उसको प्रिवेंट करने के लिए ICD की ज़रूरत है, and to prevent the progression of heart failure we would require cardiac resynchronization therapy. Resynchronization therapy कब beneficial है? जहाँ पे QRS duration wide है, and ICD कब beneficial है? Whenever there is low EF and high symptom status. So EF less than 35% and NYHA symptom status 2 to grade 4A always calls for considering ICD. In addition to that, अगर QRS wide है तो I will also require the CRT. So now look at this and tell me, what should I choose here? Should I go for CRT, CRTD, ICD or none? Ejection fraction less than 35% है, right? Symptom status NYHA grade 2 या उससे ऊपर है, so definitely there is risk of sudden cardiac death. तो उसको अवॉइड करने के लिए ICD तो ज़रूरी है ही. Disease may progress if there is bundle branch block and wide QRS. तो उसको अवॉइड करने के लिए मुझे रीसिंक्रोनाइजेशन थेरेपी की भी ज़रूरत है. So for these patients we would consider using CRTD, which is cardiac resynchronization therapy with defibrillator. But यहाँ से अगर मैं ये पोर्शन हटा देता हूँ, that QRS duration is normal, there is no bundle branch block, then we will only treat with ICD, right? We will only treat with ICD. वहाँ पे cardiac resynchronization therapy का कोई रोल नहीं रहेगा. Now the last thing is, what if despite all this patient continues to progress with heart failure and symptomatic है? So in such cases, what are the options we have? What are my last ditch efforts? So the last ditch effort, despite medical management, cardiac resynchronization therapy or the use of ICD, if the condition is progressive as a last ditch effort, I have only two choices. One is called as left ventricular assist device, and then the second one is cardiac transplantation or heart transplantation. Cardiac transplantation or heart transplantation. So left ventricular assist device क्या है? Basically we will literally assign the job of left ventricle to some external device. So instead of left ventricle doing the job of pumping, we connect your left ventricle through a tube to a pump which is kept outside the patient's body. So जो blood left ventricle में आएगा left atria से, that will be directed to this external pump. This external pump will have a tube connecting it to aorta or any of the distal branches. So it will directly pump the blood into the aorta. अब left ventricle अपना काम नहीं कर रहा है, ये assist device काम कर रहा है. Now this is right now mainly because it is not a long-term tenable solution, because we are making a tunnel to go into the left ventricle. Tube जो pump है वो outside the body है. Another tube is going into your major vessel aorta. There are risk of developing thrombus and infections. So many patients do develop complications. So it's not a long-term solution. So what we do? Standard treatment, CRT, ICD, सब कुछ help नहीं कर रहा है. So then when patient is waiting for cardiac transplantation, we use left ventricular assist device as a bridge. जब तक suitable donor मिल नहीं जाता है, जब तक cardiac transplantation नहीं हो जाता है, तब तक we can try to keep the patient alive with the left ventricular assist device. And once the patient finds a suitable donor, cardiac transplantation is our last ditch effort. Obviously, we are transplanting organ, immunosuppression की ज़रूरत भी पड़ेगी. When we transplant an organ, we would require the immunosuppression. Cardiac transplantation practically उतना आसान नहीं है, because obviously a living person cannot donate the heart. Similarly, a dead person may not be an ideal donor for the heart. So we need brain dead individuals whose heart can be transplanted. So whenever there is a need for a cardiac transplantation, finding a suitable brain dead donor may not be practically feasible. So उतना practically होता नहीं है. So in India, what we do, we mostly end up managing the patients towards the end with the CRT do. अगर affordable patient है, suitable donor मिलता है, तो we can go ahead with the cardiac transplantation. जब family suitable donor के लिए search कर रही है, तो we can support the patient's survival with left ventricular assist device. So that's it for today on the Reed Harrison series. I would recommend you to go through some MCQs from the app, primarily focusing on the role of CRT and the ICD. A lot of MCQs have been asked in recent times in the INI CT on this topic. New drugs आते रहेंगे, approval, disapproval होते रहेगा. That again pharmacology will also address. So with that, I am signing off, and as you requested, in the next session we will start with the cardiomyopathy. So we'll start discussing cardiomyopathies. We will take two sessions. In first session, we will discuss the broad classification of cardiomyopathy and different major types. In the second session, we will learn about some miscellaneous forms of cardiomyopathy like Takotsubo, peripartum cardiomyopathy, and arrhythmogenic right ventricular dysplasia. So with that, I'm signing off, guys. We'll continue our discussion, obviously, and I'll see you in the next class. Till then, have a good time. Bye-bye.